Dear students, you are welcome to this lecture. Today we are looking at aims of we are looking at management of fistulas, and we shall start with looking at the aims of managing fistulas. I'm called Kiden Robina, and I'm going to take you through this lecture, which is still part of our gynecological topics. So, what is the aim of managing fistula? One is allow fibrosis and inflammatory response to take place, clear urinary tract infections, promote fistula closure, may reduce in size or close spontaneously if well managed. So one of the ways through which we manage is hospital care. Gentle vaginal examination without instruments can be done to avoid enlarging defect. Continuous bladder drainage to support healing and prevent urine passage through the defect. Antibiotics can be given to the mother to treat any present infections, especially if detected in the blood. Balanced diet, iron and vitamin supplements can be given to the woman to improve on the health. Then blood transfusion is also given when deemed necessary. Spontaneous closure. Significant number of fistulas may close spontaneously within 6 weeks of puerperium. That is after delivery or an abortion has happened. So if continuous bladder drainage is maintained, good general health is achieved. Infection is also eradicated. The other way is vaginal antiseptic douches to manage false-smelling discharge caused by necrotic tissue. Because of this constant flow of this content, the tissues may end up necrotizing because of the irritation. So antiseptics can be pushed into the vaginal opening to make sure that the false smell that is coming from that area is eradicated. Surgical intervention, surgery is delayed until tissues have healed and strengthened. Assessment through speculum exam after the puerperium can also be done. Surgical repair is planned after adequate healing, typically after 6 weeks. So after 6 weeks, 6 weeks after delivery, if the person is now identified to be having this kind of condition, then the person can be done surgery. Bladder catheterization is stopped after 6 weeks when continuous drainage is no longer needed. Preoperative care procedures, elective admission. Admit the patient as an elective case to prepare for surgery. Psychological support, focus on restoring hope and confidence to the patient. Nutrition, provide a good diet to correct malnutrition and ensure plenty of fluids for kidney function. Then hygiene should be well maintained, especially the genital hygiene, to prevent and treat infections. Postoperative care preparation, counsel the patient on nursing positions. Prone position can be very okay for 14 days post-operative to allow the healing to take place. Preoperative care procedures. Explain catheter use. which will stay in place for 14 days or more. A theater preparation follows standard preoperative procedures. So all those standard procedures that we follow, all the steps that we follow in preparing the patient for any surgery is what we are also supposed to follow right here. Then preoperative enema should be given the evening before the surgery to ensure decongestion of the rectum. Then we should also note that colostomy may be performed during rectovaginal fistula repair. So if the mother is going to undergo rectovaginal fistula repair, then colostomy may be performed to make sure that the rectum remains empty. So all contents that will be going into the rectum should be diverted into the colostomy. Post-operative nursing care for positioning initially in a semi-prone position until the patient regains consciousness, then in a prone position for 14 days. Catheter monitoring, observe catheter for drainage, color, and potential site leakage. Report any abnormalities. Bladder irrigation may be needed, performed by a doctor. Routine care, continue with the standard post-operative care. So bladder training post-surgery. After the surgery has been done, when the opening has been repaired, how is the bladder trained to ensure that it functions as before? So bladder training begins after 14 days post-operatively if no leakage is observed. So immediately after the surgery has been done in the post-operative care, the patient is supposed to be observed for any leakage. If leakage occurs during the period of recovery, then it means that the surgery was not successful. But if it does not occur, then it means that it was successful, and because of that, the bladder training has to begin after 14 days. So what is the training schedule? So the training schedule is like this. In day 1, spigot the catheter, remove the urine bag, then you release urine hourly during the day. Then keep CBD at night. Now, during the daytime, the catheter will be closed. That's what we mean by spigoting. You close the catheter, you remove the urine bag, then make sure that urine does not flow. So the urine will be retained in the bladder for like 1 hour, exactly 1 hour. Then you open the spigot, or you open the catheter. Then the urine drains out all. Then after that, you close again. You wait also after 1 hour, you do the same. But then at night, you need to keep the continuous bladder drainage, so that because at night it will not be possible to do it on hourly basis. Then day 2 is you also spigot the catheter, release urine 2 hourly. Then at night also maintain the drainage, meaning that you will connect the catheter again, then it drains again. This is what we mean by CBD, continuous bladder drainage. Then day 3 and 4, release the catheter during the day, continue with CBD at night. So in day 3 and day 4, the catheter will be released during the daytime. Then now at night, it will be connected back. Then day 5, remove catheter. Ask the patient to hold urine to measure bladder capacity, then void and catheterize to measure residue urine. So what will happen in day 5 is the catheter will be removed. Then the patient is told to hold the urine, then urinate, and when after urinating, the catheter will be a catheter will be inserted again, and when the catheter is inserted, there will be some urine, of course, that will drain, and that is what is called the residue urine, which is always in the blood. So this will be measured to see the capacity of the bladder to hold the residue urine. Now, successful training, residue urine should measure less than 100 milliliters. For you to declare that your training has been successful, the residue urine that you measure on day 5 should measure less than 100 milliliters. But if it measures more than that, meaning that the training is still not effective. Then unsuccessful training, residue urine greater than 100 milliliters, then that means that you need to continue the CBD and the bladder training until you become successful. Nursing concerns, psychological impact. Mother may feel miserable and depressed. Physical issues, continuous leakage of urine or feces and foul smell. Infections, risk of urinary tract infections because of the continuous flowing of the residues. Nursing care plan. 1. Ineffective individual coping. Diagnosis related to continuous dripping urine, because the urine is dripping all the time, so the person will feel like she is not fitting in the environment. So what is the expected outcome? What we expect is mother verbalizes coping mechanisms by day 3. So by day 3 of bladder training, we expect that the mother should be able to verbalize that she is now able to cope well. So interventions, what are we going to do? We reassure and explain fistula cause to the mother. Then promote cooperation through information and procedure explanation. Then answer all questions that are asked by the mother so that she can get to understand her condition very well. So what is the rationale? The rationale is to promote coping, reduces anxiety and encourages cooperation. How shall we evaluate? In evaluation, by day 3, mother should verbalize coping strategies. Knowledge deficit. This is another nursing diagnosis. Knowledge deficit, the diagnosis related to the cause of condition, which is fistula. So expected outcome, mother should be knowledgeable about the fistula by day 5. Interventions, answer questions. So whatever questions that the mother asks, the nurse should be in position to answer. Explain the cause of fistula. Explain each step of the treatment. Rationale. Provides comfort and promotes understanding of the surgery. Evaluation. By day 5, the mother should express understanding of the cause of the fistula. The other nursing diagnosis is risk for impaired skin integrity. Diagnosis related to continuous leakage of urine. The mother will feel like she will feel very uncomfortable because of the fact that there will be irritation, especially around her private parts and also in the thighs. So, and most likely the skin may be damaged. It might not be damaged by then. That's why we are doing this as a risky nursing diagnosis. So, expected outcome, mother's skin should remain intact. Interventions encourage frequent bathing and skin drying, change pads regularly, provide a nourishing diet, treat any rationale, prevents skin irritation, supports healing, and prevents infection. Evaluation, mother's skin should remain intact throughout. Advice on discharge, sexual activity. Avoid coitus for 3 months. Cancel both partners on abstinence. So in this case, it is not like maybe the person can use protection or what. No, it should be abstinence to ensure that the healing process is not interfered with. Family planning, avoid pregnancy for 2 to 3 years. Antenatal care, disclose fistula history to attending midwife or doctor for future pregnancies. Activity restrictions, avoid strenuous work, rest for healing. Hygiene, maintain vulvar hygiene to prevent infections. Nutrition, ensure a nourishing diet to aid recovery. Follow up, regular review at the gynecological department is very important. Prevention of obstetric fistulas. One is antenatal care, early screening for high-risk mothers to prevent obstructed labor. Support, provide continuous support from trained healthcare professionals during pregnancy. Family planning, encourage spacing between births and support education for girls. Prevention strategies, improved nutrition and physical maturity of young mothers, access to timely and safe deliveries, that is emergency obstetric care, is very important. Prevention of obstetric fistulas, training local healthcare providers to perform cesarean section, community education on the risks and the prevention of fistulas. These are very, very important. Complications, stillbirths due to prolonged labor, severe ulcerations, damage from prolonged pressure, foot drop, paralysis of the lower limbs caused by nerve damage, sepsis due to infection spread, then amenorrhea. A significant number of women may stop menstruating post-fistula repair because of some damages. So that marks the end of our lecture today. Thank you for being part of it.